So today I will be doing a quick discussion on tension pneumothorax. In this type of pneumothorax, as we know that in pneumothorax normally air comes into the pleural cavity from the atmosphere, but in this case the air that comes into the pleural cavity they occurs by ball valve mechanism, okay, which means that it begins to accumulate into the pleural cavity but it does not go out. So it creates a lot of tension in the mediastinum and causes mediastinal shift to the opposite side, okay. And also what happens is that because of this increased accumulation of air and no way of for it to go out, it is just continuously going in, okay, one way mechanism is occurring, so pleural cavity pressure becomes more than the atmospheric pressure, okay. These are the typical presentation of pneumothorax which occur in all patients on pneumothorax: pleuritic chest pain, breathlessness, absent breath sounds. Compare this with Beck's stride, in which there were no hard sounds for cardiac tamponade, but in tension pneumothorax there are no breath sounds, okay. This is how you differentiate the scenarios, okay. And chest can be expanded on inspection, okay. And on auscultation, of course, you won't find any breath sounds. Other than those typical symptoms, if there is mediastinal shift on the chest X-ray or hypotension, this means that this is a tension pneumothorax, okay. Now this thing about mediastinal shift is purely theoretical because you don't have time to perform a chest X-ray. Never send the patient for an X-ray when you are suspecting a tension pneumothorax, because that is equivalent to taking his life, okay. You don't have that much time. You just quickly have to treat it. And how you're going to treat it? You're just going to quickly do needle decompression in the second intercostal space. Just insert a needle and you're going to hear the air will just come out with a gush. Suddenly a lot of air is going to come out. So this is going to confirm that yes, this was a tension pneumothorax. And after doing this needle decompression, you are going to do this. You are going to insert a chest tube, okay. Intercostal tube drainage is going to be done, and you have to insert this tube and you have to attach it with underwater seal. Why is this underwater seal important? Because this underwater seal has an air fluid column, okay. You look at this air fluid column, whether it is moving or not. When it stops moving, this means that the lungs have progressively re-expanded. So this is the main thing. So the first thing that we have to do, that you have to do a needle decompression, okay. You have to do a needle, and then you have to insert a chest tube, okay. Now the important thing that students get confused is that needle decompression is to be done in second intercostal space, and chest tube is going to be inserted in the fifth intercostal space in the triangle of safety, okay. There is this triangle of safety which we will discuss in the upcoming discussions. That is where you are supposed to insert the chest tube.